Thank you for joining today's webinar hosted by Hologic, Antenatal Steroids, Expanded Role in Improving Outcomes. I'm Susan Hepworth, and I will be facilitating today's webinar. Today's agenda is as follows. After my brief remarks, we will hear a presentation from Dr. Lucky Jain, Pediatrician-in-Chief at Children's Healthcare of Atlanta. Following Dr. Jain's presentation, we will have time for Q&A with attendees. And at that time, Dr. Jain will be joined by Dr. Michael Ruma of Perinatal Associates of New Mexico for that Q&A. Following the Q&A, that will conclude today's webinar. A couple of logistics items. We have reserved dedicated time at the end to answer your questions. So please use the Q&A box to ask a question. You can also send a chat to me if you have any questions or feedback using the chat button. Feel free to submit your questions at any time during the program. There is no need to wait until the end to submit those questions. We'll put them into the question queue for you. So with that, I have the pleasure of introducing today's speaker. Dr. Lucky Jain completed his medical degree and residency at the University of Rajasthan in Jaipur, India. From there, he was awarded a Rotary International Award for Advanced Training in Pediatrics and Neonatology, which marked the start of his illustrious career in pediatrics. Dr. Jain is a specialist in respiratory disorders of newborns and is credited for highlighting the role antenatal steroids play in fetal lung fluid clearance and the ensuing multi-center trial of antenatal steroid treatment in late preterm gestations. He currently serves as Pediatrician-in-Chief at Children's Healthcare of Atlanta, as George W. Brumley Jr. Professor and Chair of the Department of Pediatrics at the Emory School of Medicine, and as Executive Director of the Emory Children's Pediatric Institute. So Dr. Jain, go ahead.
Well, thank you, Susan. Thank you, Dr. Ruma, for the invitation. Folks, I am delighted to join you all this afternoon to talk about a topic that is very near and dear to my heart, the topic of antenatal steroids. I believe that most of you know much about this topic already. My goal here is to give you a slightly different perspective and build for you the background from which neonatologists approach the treatment using antenatal steroids in preterm births. So it's remarkable that since the 1960s, when the NICUs first opened, premature babies then had a 95% chance of dying. Today, they have a 95% chance of survival. I challenge you all to think about a single area in medicine that can boast this type of a statistic. You can think about cancer, heart disease, anything. I challenge you to think about such a remarkable reversal. Much of this reversal has been due to gains, due to technological and biological advances that we've seen over the decades. However, as a neonatologist, I can tell you that much of the gains have been also due to tremendous improvements in obstetrical care, standardization of what you do, and quality improvement across the board. And so first and foremost, I want to thank all of you for your commitment to your profession and what you have done partnering in partnering with neonatologists across the world to improve neonatal outcomes. That said, perinatal health challenges remain. There's an unacceptably high rate of preterm birth, ranging anywhere from 5% to 15%, 20%, depending on what part of the world you come from. Morbidity and mortality rises with each week lost below 39 weeks. simple problems that I thought during my fellowship would be long gone are still there. Deaths from birth asphyxia, hypoxic ischemic encephalopathy, newborn sepsis continue. There are proven therapies that take forever to be implemented. And then there are unproven therapies that abound. Globally, there are about 120 million live births. And if you average out 13% or so preterm births, that's a pretty large number. And of these, about 10 million are late preterm births. Many of these babies, as you know, have respiratory morbidity, whether it is RDS or TTN, pulmonary artery hypertension, apnea, or the need for respiratory support due to a combination of these. There's also this other fact that a lot of late preterm babies are delivered by cesarean section, often in situations where the obstetrician has no chance to let the mother go through labor. And up to 30% of these babies that have a combination of late preterm birth and cesarean section develop respiratory distress, with the primary problem there being fetal lung fluid clearance issues. And as I mentioned, there's a higher rate in fetuses that have never been exposed to labor. I bring to your attention a study from several decades ago where a group in Italy compared planned vaginal births to what they then over there called elective cesarean sections. And what you see, the gap between the red line here and the bottom line is respiratory morbidity, meaning that for every week that you see on this curve, until you get to about 39 or 40 weeks, there is a gap between cesarean birth and planned vaginal birth. And part of the reason is that ability to clear fetal lung fluid really peaks at term gestation. And that surfactant maturity is not an all or none phenomenon, that there is progressive increase in lamellar bodies and actual surfactant quantity in the amniotic fluid and in the fetal lungs. I guess Mother Nature intended to do that because there's got to be some reserve in something that is as important as surfactant. And then there are these developmentally regulated proteins, which I spent my entire career studying, and I'll speak briefly to the epithelial sodium channel that my lab studied for almost 20 years. So this is a graph that I have used in my basic physiology lectures for the medical school M1 class for years. Majority of people out there still don't think of fetal lung fluid as being fluid that is secreted by the lung. The assumption is that if the baby is submerged in a amniotic fluid, that it's probably a mixture of amniotic fluid and some fluid from within the lung, or really mostly amniotic fluid. Well, most of this fluid is secreted actively by the fetal lung. And the fetus has to know somehow that it is time to be born and turn off this active secretory process. The amount of fluid made by the fetus is large, 100 to 200 mils per kilo per day in the lung, and that fluid pours out into the amniotic fluid, carrying with it surfactant. And that is why you as an obstetrician can test the amniotic fluid and tell whether or not the fetal lung is mature, because you have dynamic real-time communication between the fetal lung and the amniotic fluid. So what you see here in this graph is that somehow in natural labor, the fetus comes to know even before labor sets in. This is generally hours to a day or two before labor, active labor starts, that the fetal lung fluid clearance starts. And then during labor, the fetal lung fluid goes down even further, so that when a baby is born, there's only about 40% or so of the original amount of lung fluid that the fetus had. And that is much easier for the baby to clear after active breathing starts. And so you can tell from this graph then that if a baby were delivered by a, let's say, cesarean section or sudden delivery where there was no notice to the fetus, that the amount of fluid to be cleared would be substantially larger. And this is shown here in a slide from one of my lab publications in the American Journal of Physiology from years ago, that the paradigm for fetal lung fluid clearance involves a very elaborate machinery of ion channels in the lung that initially sodium moves from the alveolar spaces into type 1 and type 2 cells. And then that sodium is pumped out of the cell by an enzyme called sodium-potassium ATPase. Anytime sodium moves, chloride moves with it, either through CFTR or through paracellular pathways, and that drags water with it, and there's plenty of aquaporin channels in the lung, and this leads to net movement of salt and water, leading to clearance of lung fluid. Now, the remarkable thing about this is that if you knock out this particular channel, ENaC, in a mouse model, there's 100% mortality in the pups, and they all die because they cannot clear their lung fluid. And so that was the first indication that active processes, or an active process that involves the movement of ions, is what helps the baby after birth clear its lung fluid. And so then the question came up, what is it that activates lung fluid clearance, and could we use that from biology to bedside as a mechanism to improve fluid clearance? And from my own lab, we discovered over the years that corticosteroids, catecholamines, vasopressin, and aldo are the prime targets that convert essentially the fetal phenotype, which is secretory, to adult phenotype, which is absorptive. And that is the combination of steroids, catecholamines, and air breathing. What we were also able to show right around that time is that if I take fetal cells and expose them to steroids overnight, I'm able to convert the phenotype from secretory to absorptive phenotype. And much of this is because of this green bar, which shows expression of highly selective sodium channels. And in the absence of steroids, you see the bar over here on your right-hand side, the green bar is practically absent, which shows that this is the equivalent of what the knockout mouse is, where fetal lung fluid clearance is problematic. When Dr. Liggins did his study 50 years ago, the focus was almost entirely on surfactant. Not much was known about lung fluid clearance, and not much attention was paid to what happens there. What the study did show in Australia is that of the 213 patients in preterm labor who were randomized to betamethasone or placebo, there was a remarkable reduction in perinatal mortality from 15% to 3%. An equally remarkable reduction in RDS from 26% to 9%. The maximum effect seen was between 26 weeks and 32 weeks. And the maximum effect was also observed if the steroid was given 2 days to 7 days from, or the delivery happened between 2 and 7 days after the first dose was given. Please make note of this, because I think this has great relevance to where we are today, where a lot of steroid treatment, antenatal steroid treatment, is done without reference to these numbers, and a lot of mothers end up receiving steroids and not delivering for weeks after that, which does many things, including exposure of the fetus to heavy dose of steroids, where delivery was not really anticipated. The NIH consensus statement in 1994 said the effect of steroids on fetal maturation shows reduction in mortality, RDS, IVH, and confirmed pretty much the fact that these are not limited by the baby's gender or race, and the benefits are greatest when the treatment is more than the delivery is more than 24 hours after the start of the course. But there was delayed adoption of steroids for many reasons. People were worried about long-term impact. But then follow-up studies in children as old as 12 years old after the treatment showed no delay in physiologic growth or psychomotor development. And it was estimated that antenatal steroids would result in substantial savings and health improvement. And it was largely because steroids stimulate cytodifferentiation in a variety of fetal and neonatal tissues, including remote organs like the gut, where it enhances maturation of glands, villi, improves digestive function. So people began, at least in the neonatology field, believing that in the brain, for example, if it accelerates myelination and functional maturation, then maybe that is what is preventing IVH. However, during that time, a gap remained in that we thought more or less arbitrarily that 33 weeks or less steroids work, and that magically or not so magically, you're a day over 33, 6, 7 weeks, the steroids stop working. But how can that be, given how inaccurate our dating is and how inaccurate within a week or a week and a half our estimates are? And so in countries like England, they had already begun including 34 weeks and 35 weeks in their antenatal steroid treatment. But there was lack of data on efficacy and underappreciation of the neonatal risk. And so we hypothesized that in infants at high risk for late preterm delivery and mothers too, that administration of antenatal betamethasone would decrease the need for neonatal respiratory support. The NICHD at that time had convened a consensus meeting, and I was invited as a neonatologist to speak on respiratory transition, and I proposed a study at that time. It took many years. It took 5 years to get appropriate funding, ultimately to start the study. And what I'm hoping to do in the next few minutes is to review with you the results of the trial, because I think that to many practicing physicians, including myself, I am not willing to just take the summary from an abstract and start doing things. I want to always try to understand how the results that were published were derived. And so this study that was published in 2016 in the New England Journal of Medicine represents probably one of the largest studies done in preterm or late preterm population. The lead author was Cynthia Jamfi. At that time, she was in New York, Columbia, and I served as the senior author and also the only neonatologist working with maternal fetal medicine centers across the country. And I had the proud privilege and work assigned to me of reviewing every adverse neonatal outcome in the entire study that could not be verified. So all X-rays were sent to me, and of course, everything was blinded. The eligibility for that study was women who were in preterm labor or had a high likelihood of delivery from 34 to 36, 6-7 weeks gestation. We had specific criteria moving into the study that membranes needed to be intact, at least 3 centimeters dilated, or 75% effaced. Preterm prom was included if the, so each of these criteria allowed for inclusion. And for indicated preterm delivery, it was either provider discretion and the hope that delivery would occur within a specific time period after randomization. Exclusion criteria included premature prolonged rupture of membranes with active labor, and the likelihood that the mother would deliver fairly soon after steroids were given and not have enough chance of the steroids acting. Chorioamnionitis was a contraindication, as was cervical dilatation of 8 centimeters or more, non-assuring, fetal status, and delivery expected within 12 hours. Other exclusion criteria included previous course of antenatal steroids, pre-gestational diabetes, known fetal anomaly, and any other contraindication to betamethasone. We randomized these mothers in a 1-to-1 ratio to either 2 doses of 12 milligrams each betamethasone to 24 hours apart, or identical placebo. Tocolysis was not employed as part of this trial, and the analysis was by intention to treat. The trial design was multi-center, double-blind, randomized, placebo-controlled trial with 17 maternal fetal medicine units across the country participating. These were both academic and community hospitals, and I say that because that represents then the generalizability of these results. The study, including all data collection, occurred between 2010 and 2015, and the results were published in 2016. Our primary outcome was not RDS or TTN, because we didn't know really how many of these babies would have surfactant deficiency versus lung fluid clearance issues. And so we said, really, what matters to the clinician is whether or not the baby born after birth has respiratory distress or not. And so the primary outcome was a composite combining need for respiratory support, which included more than 30% oxygen for at least 4 hours, the need for CPAP or a high flow nasal cannula, mechanical ventilation, which means intubation and being on a ventilator, need for ECMO, or neonatal death. All of these within 72 hours after birth. Secondary outcome, which was from a neonatal standpoint equally important, but would have required a much larger sample size to prove, was oxygen requirement for greater than 30% for at least 24 hours, and CPAP or high flow nasal cannula for at least 12 hours. And this included everything else in the primary outcome, including ECMO, death, etc. So here are the randomization numbers. Of the 2,800 patients we enrolled, the distribution between betamethasone and placebo was pretty much equal. Only a couple in each group were lost to follow-up, and so we had a very robust group to look at. Gestational age at trial entry is listed on this slide. You see that the two groups were comparable. What you also see is that there were more babies at 35, 36 weeks gestation than at 34 weeks gestation, which would reduce the power of the study. Gestational age at delivery, 34 weeks was 15.2 weeks, and babies that delivered at or after 37 weeks were about 16% or so. And you see the rest of the numbers are listed there. The next couple of slides give you other baseline characteristics, and I wanted to share these with you. Normally for neonatal lectures, I skip these, but I thought that they would be of relevance to you to see that between the two groups, there were no differences when it came to rupture of membranes, gestational hypertension, preeclampsia, or other complications like fetal growth restriction, oligohydramnios, etc. And other baseline characteristics like minority status, gestational diabetes, etc., were also very similar. The other fact that I wanted you to see is that 60% of our patient population received the second dose of the study drug before delivery occurred. So 40% received only one dose, which is a testament to how randomization was done in that most mothers were predicted to have imminent delivery. And the time from randomization to delivery was again comparable between betamethasone and placebo group. So here are the results of the Alps study, that when you look at the composite need for respiratory support, there was a 3% absolute reduction in the risk for need for respiratory support, which when you convert into number needed to treat would be 35 mothers would need to be treated to prevent one newborn from developing respiratory or needing respiratory support. In relative terms, that would be roughly about a 25% reduction in the need for respiratory support. That is 3% divided by 11.6%. For secondary outcome, where we needed at least 24 hours of oxygen need and baby being admitted to the neonatal ICU, there was a 4% difference in that outcome, and the number needed to treat actually dropped to 25, surprisingly. And the result was highly significant, given that if you look at the placebo group, 4 divided by 12.1, that is a 33% reduction in severe respiratory morbidity. I will just let you glance through the rest of these results in that we tracked a lot of outcomes, including transient tachypnea of the newborn, respiratory distress syndrome, BPD, surfactant use, etc. And the p-values are p-values. Ultimately, the bottom line is that whether or not babies required respiratory support was much, much more important to neonatologists who were going to use or recommend this treatment. We had very few severe patients with severe morbidity, including IVH and death, etc. And so that's why you don't see any significant relative risk ratios or p-values. One striking finding was that hypoglycemia, defined as glucose levels below 40 milligrams per deciliter, was significantly higher in the betamethasone group, 24% versus 15% in placebo group. However, when we looked at time to first feed, it was earlier in betamethasone, and the NICU stay or intermediate nursery stay was similar in the two groups. The intermediate NICU stay for greater than or equal to 3 days was actually lower in the betamethasone group as compared to the placebo group. What we also saw was that time from randomization to delivery for the hypoglycemia group was about 30 hours compared in hypoglycemia versus 34.6 in no hypoglycemia. And that it was highly significant, and it's relevant because if a mother is given 2 doses of betamethasone or 1 dose of betamethasone, we see a spike in their blood glucose levels, and if delivery happens soon after that spike, then the risk for neonatal hypoglycemia increases, obviously, because the fetus responds by secreting insulin, and that drives the glucose down after birth when maternal supply of glucose tapers off. So in summary, then, the results of this study showed that antenatal betamethasone given to women at high risk for late preterm birth significantly decreased the need for respiratory support. It also decreased the relative risk ratio for prolonged stay in the NICU, transient tachypnea of the newborn, the need for surfactant use, bronchopulmonary dysplasia, even though the numbers were small. We found no difference in maternal or neonatal infectious morbidity. We found no difference in birth weight or gestational or small for gestational age infants. The beneficial effect was seen even in the absence of tocolysis. Hypoglycemia, which is a known late preterm complication, occurred more frequently after betamethasone exposure. However, it was not associated with longer NICU stay or stay in an intermediate care nursery. But it does suggest that postnatal glucose will need to be regularly monitored after this type of a treatment. Now, this study was published in 2016, February. I guess a few months later, the Society for Maternal Fetal Medicine issued a statement recommending implementation of the use of antenatal steroids in late preterm births. And soon thereafter, the Canadian Society, so this is October of 2016, soon thereafter, the Canadian Society and then the European Society issued their recommendations that antenatal steroids be used in gestations 34, 35, and 36 weeks. Right around that time, there was work going on in many countries, wondering if fetal lung fluid clearance could also be enhanced in elective cesarean births. And Aztec's study was going on. Results of that study were published around that time as well, and that showed a reduction in neonatal morbidity after steroids were given to mothers who were undergoing elective cesarean birth. Now, I show you these couple of slides to say that the recommended practice based on the study is that we did not study twins. At that time, we said we don't recommend giving it to twins or giving it to mothers who are diabetic. We did not include diabetics, mainly because our IRB said that it would unmask the study and randomization would become apparent to people, because in diabetic mothers, you give them steroid, their blood glucose will spike. And that would indicate that the mother had received the drug, not the placebo. We recommended that moms with chorioamnionitis not receive this treatment. And we also said that we should not give steroids if delivery is not likely before 37 weeks gestation. Yet, what you see is in real life, these are data from a recent study where more than 60, almost 65% of mothers who were given antenatal steroids delivered at or after 7 days of treatment, which was not the intent. Remember, the intent was 2 days to 7 days is the window when you have the least number of side effects or and the greatest risk-benefit ratio. So that's the actual practice. More recently, this is a study that Dr. Ruma sent to me, and I was actually very happy to see this recommendation from the Society for Maternal Fetal Medicine, where they indicated that a quality metric for timely use of various modalities, and that included emphasis on using steroids in a window where delivery could be predicted. We still have many unanswered questions. And my goal here today, as I explained to Dr. Ruma and all of my colleagues, including Susan, Jesse, and others, is that there's still lingering concerns about long-term outcomes and exposing a large number of mothers and babies to steroids. There are also concerns about not being able to rule out chorioamnionitis confidently in developing countries. And there, if you give antenatal steroids to a mother who has chorioamnionitis and the mother doesn't deliver soon thereafter, there is a higher risk for infection-related complications. We are conducting a follow-up study on the late preterm Alps babies to look at respiratory outcomes. We were not funded at that time to look at long-term neurologic outcomes. The logic at that time was that unlike a 24-week gestation baby that gets exposed to steroids and doesn't deliver until, let's say, 38 weeks, that's 14 weeks of exposure to steroids because steroids are recirculated within the fetal system. Compared to that, if a mother is at 35 or 36 weeks gestation and you give the mother antenatal steroids, then as you saw, majority of the mothers had already delivered by 33, on an average 33 hours. So the exposure to steroids is much shorter because after birth, the baby starts to pee, metabolize steroids out of the body, unlike in the closed amniotic fluid system, where the fetus continues to pee, urinate into the amniotic fluid that gets swallowed by the fetus, and steroids keep on recirculating through that mechanism. And so to summarize here, I have to admit to you that at this stage in my journey as a neonatologist, I'm still baffled by the unacceptable or the really high rates of preterm births. I'm still baffled by why we have not been able to reduce complications after birth that are often preventable, and why we are not able to use antenatal steroids more precisely within the windows that have been shown to be the most effective, and also in mothers where it would be safe to use. I'm also a little worried that further studies are needed but have not been done. There are places in the world where I've been to where more than 50% of moms are delivered by planned cesarean sections. And when I go to their NICUs, there are very few preterm babies in their NICUs. They're all big term babies huffing and puffing away because their lungs are full of fluid. And in those countries, many of those countries, they've already started using antenatal steroids to improve lung fluid clearance without really any good randomized study or long-term outcome studies to prove things one way or the other. And so I want to end here by saying that for all of us, who work in demanding fields like OB, GYN, neonatology, we've been impacted to a much higher degree by recent challenges. I list here a challenge that all of you are well familiar with: 604 million cases now of COVID, 95 million cases in the US. You all and we have been in the front line. And I've lost colleagues to and fellow physicians who died in the early pandemic, 2020 and 2021, when the new variants started to arrive. I experienced firsthand in my faculty burnout and long haul syndrome. There are many who are continuing to struggle with impact of what happened 2 years ago or a year ago, where a family member was lost or they themselves had long COVID syndrome. There is this fatigue that has developed, and I have a hard time putting my finger exactly on what it is. My wife, right there in that picture behind me, is an ER physician here in Atlanta. And I remember in the worst of the days of the pandemic, she went with her N95 every single day to the ER or whenever her duties were. Came back every time worried about protecting herself and her family, with two young grandchildren who had moved in with us. She talked about witnessing untold misery and talked about the uncertainty of disease that surrounds us, staffing challenges that we were facing. And really, there was no end in sight. And I personally don't see any end in sight even now. I'm not trying to be pessimistic. I'm just saying that as a department chair in a system that has 250,000 ER visits in a year, I see this constant barrage of people who break down and who come to me and talk about how their lives have been impacted. I do, when I hear those types of issues, I always ask them 3 questions, and I'll pose these to you as well. In the silence of your cameras and your laptops, I'd love for you to jot these down and try to answer them. The 3 questions are: what I do in my job, is it joyful? Do I have the right skill set? And what I do, does it matter? Is it meaningful? And I urge all of us as a profession to keep thinking about what is it that we can do to restore the joy of practice, to make sure that all of us collectively and individually have the right skill set to operate and do our job at the highest level. And I don't need to, with 2 grandchildren right there in that picture looking at me and all of you, that what you do is so meaningful, because had it not been for the care that our daughter received in New York, where she delivered, our grandson wouldn't have been alive today. And so what you do provides hope to people and gives a chance to life to many mothers and babies that otherwise would not have it. So with that, I want to thank you, Dr. Ruma, and everyone else for giving me this opportunity to share my thoughts with you. And obviously, I would love to field questions from you. But I want to end by saying that our winding roads to professional happiness have to start with us feeling that we are strong enough to care. Thank you very much.
Thank you so much, Dr. Jain, for that excellent presentation. We'll ask Dr. Ruma to join us on the screen. And Dr. Jain, if you want to stop sharing so everybody can see you and Dr. Ruma just a little bit bigger. We've been receiving a lot of questions, and so I've got them queued up here. So I think some of these it'll be obvious to who the question is. Some of them I think both of you may want to answer. So we'll go ahead and get started. As a neonatologist, is there advice you would give your OB or MFM colleagues when we are managing an obstetric patient in a setting of anticipated preterm birth?
Right. So I think, Mike, I would love to get your thoughts on this. I feel that we are generally at the receiving end, and we don't know when when the decision was made to give the mother antenatal steroids or to tokenize the mother. That decision is made by the obstetrician. But I'm always intrigued when I see a mother who received steroid 3 weeks before delivery. And then I'm wondering, how did we go so wrong with our estimate? I'd love your thoughts about that.
Yeah, the reason this question I think is important, and thank you, Dr. Jain, Lucky, for an awesome and very educational lecture. Really appreciate you taking the time. The reason I think this question is important is just that in my mind, as an MFM specialist, obstetrician at heart, we're going to hand a preterm infant to the neonatology team. And I think, at least in my experience over the years, we used to have lots of communication with our neonatology colleagues. But like you said, due to, maybe strains of COVID and the pandemic, we've seen these stressors play an effect on our communication. And I guess my takeaway as an MFM would be, I hope that we, before handing a preterm infant and thinking about a preterm delivery, that we're actually talking to our neonatal colleagues, what can we do better to prepare? Have we given antenatal corticosteroids? Is magnesium sulfate, something that's useful? Are antibiotics necessary? And so I think it's a pertinent question. And I was just curious if from a neonatologist perspective, if you had, any advice for your colleagues in the obstetric world.
Yeah, no, I think you're spot on. It's really one of those things that the more we communicate with each other, ultimately, the better we are. I'll give you one other example, Mike, that for a while there was a growing trend of delivering babies with congenital hearts or diaphragmatic hernias at a time when everyone was around with the hope that those babies would then get better care. However, studies showed that the outcomes in those babies were actually worse than the ones that delivered spontaneously. So it's that type of consideration that needs to factor into our decisions, where we are not only thinking about the mother, but we're also thinking what the impact is going to be on the unborn baby. And I think that the concern that a lot of neonatologists and obstetricians express is more related to prolonged courses of and multiple courses of antenatal steroid that go endlessly, and you end up seeing that the brain size of the baby is smaller, and neurodevelopmental issues then start taking over, where the risk of mild respiratory distress was relatively small.
So kind of as a little bit of a follow-up to that, I guess, then what does the communication between the neonatologist and the labor and delivery team usually look like?
I can start with that one, Lucky. I think, many times, as Lucky had mentioned, in anticipated, consideration of deliveries of complicated babies with fetal abnormalities, Ideally, this is, consideration of when we're going to do it, where we're going to do it, and early involvement of all the team that's actually going to have to touch that child, the neonatologist, the pediatric surgeon, pediatric anesthesia. So I think that is very early communication. And then maybe I'll let you tag team Lucky on that. That would be our initial very early communication really at the time we make those diagnoses.
Yeah, no, I think, Susan, there are obviously two aspects to this. There's the communication that needs to happen before the mother gets into labor and delivery room. And then, of course, once the decision is made and the delivery is likely to happen, then what type of pediatric team needs to be there, what type of preparation needs to happen. I think that there is, at least at my center, there is remarkable collaboration between the teams. It's just that there are some decisions that are made remotely in an obstetrician's office that often don't get communicated to, or there is not as much input from a neonatologist as I was used to when I was a fellow in training in my early years. Our MFM chief at that time was Bill Spellacy in Chicago, and we would meet with our MFM team every week. We would have a meeting, a joint meeting in the NICU, and they would present all their high-risk cases and look for input on what the right approach ought to be. That part, I feel, is missing now.
Yeah, I can just comment on that. I mean, I think in my training, it was similar to a week as well. But today, at least in my practice, we were down, just burden of meetings. We do that still, but as a once a month occurrence.
Yeah.
Well, some more questions have come in here. What are the immediate effects you see after a preterm birth when ANCS have been given with proper timing?
Right. So, Susan, I think that was the crux of my study presentation, that there is a 33% reduction in severe respiratory distress, almost 25% reduction in mild respiratory distress. And the underlying pathophysiology, by and large, is better clearance of lung fluid, even though we didn't specifically measure lung fluid in these babies because that's very, very hard to measure. But the mechanism is pretty solid because, and in particular, Mike, if we had pregnancies where amniotic fluid testing had already shown that surfactant is mature, then giving steroids wouldn't add a whole lot to reducing surfactant-related neonatal respiratory distress. The impact is largely on accelerated lung fluid clearance. The downside, Susan, as I mentioned, is hypoglycemia, which fortunately is very transient, but does need to be monitored. And within that framework, I think I'm always reminded, Mike, of a story that I often start my medical school lectures with, that years ago when Mr. John F. Kennedy was our president, Jackie Kennedy had a preterm birth. At 35 weeks gestation, Patrick Kennedy was 2.1 kilos at birth. No antenatal steroids were used at that time, and Patrick developed severe respiratory distress. There was no way to manage babies of that type. There were no ventilators in the US, but the president did not want the baby to be taken to Canada where they had the ability to do it. And so Patrick was actually given hyperbaric oxygen, ultimately died, had a massive intracranial hemorrhage and died. And looking back at that now, 2.1 kilo baby, I mean, there is no chance that we would let a baby like that, particularly a VIP baby like that, die, or have such severe outcome. So anyways, yeah, I think that care has evolved since then, and overall, the maturational effects of steroids are seen not just in respiratory system, but also in gastrointestinal and overall maturity, ability to feed as well.
Okay. The next question is, as a neonatologist, have you seen any association of behavioral or attention disorders in children after in utero ANCS exposure?
Right. So there are reports out there. My ability to track these babies ends when they are discharged from our NICU. But there are reports out there. See, the problem is that we always deal with as clinicians. People are still asking this question about COVID vaccine. They're asking, after COVID vaccine, do you ever see myocarditis or menstrual issues or lost pregnancies, etc. The way to approach this question is not, have I ever seen this? The approach is, compared to people who did not receive the vaccine, COVID vaccine, what is the relative risk or the cost benefit ratio to people who received the vaccine? And the emphatic answer to that is that vaccinated people have much lower morbidity and mortality, short-term, long-term. You look at whatever way you look at it, and a lot of that applies to properly used antenatal steroids as well. And the fact is, Mike, that if you look at now almost 30 years of antenatal steroid use at 30 to 33 weeks or less, the question often comes, well, how different is one day more and 34 weeks when we traditionally stop using it? So either we say we are concerned about all preterm births, and the ability to predict respiratory distress is actually very limited.
I might have a follow-up, Lucky, if you would mind. Obviously, you've done a tremendous amount of research in the laboratory. These studies on neurocognitive outcomes in children long-term, I think we know that repetitive dose steroids given weekly, where mothers were getting 2, 3, 4, 5, 6 courses of steroids, 10 or 12 injections of steroids, caused some evidence of microcephaly that maybe did catch up, but initially was a problem. So could you comment just on, as a scientist, biologic plausibility of early preterm steroid exposure at 24, 25 weeks, where maybe the patient, that fetus, that infant doesn't actually deliver preterm? I mean, could it actually happen? Is there an association?
Oh, it's not could it happen? It happens. I mean, all of us have seen not just case reports, but series. I mean, I have moderated a session a few years ago where they tracked the risk of cerebral palsy after multiple courses of steroids. I mean, that risk is real. And I want all of us to acknowledge that we're not here to push antenatal steroids. We're just here to state facts that used judiciously in a balanced way, there might be a way to reduce morbidity. However, I can categorically tell you that multiple courses, like you said, Mike, where 5, 6 courses were given, and the mom didn't deliver until 10 weeks later, and that's why you had to give 5, 6 courses of steroids. The impact of steroids on reducing growth, somatic growth and neurologic growth, is clearly seen. and that is a scary thing for us to see. And the thing is that there is a sweet spot in the place where you maximize the effect, and then beyond that, the risk of complications, actually, the benefit goes down and the risk of complications continues to go up. And so neurologic complications are definitely something that we need to warn the mothers about, particularly if we are planning on using multiple courses of steroids.
Okay. I think we've just got time for a couple of more questions. This one is about medically complicated pregnancies, such as diabetes, hypertension, or preeclampsia. Do antenatal corticosteroids have similar effects?
Right. So since then, other studies have also shown, Susan, that steroids are efficacious in preeclampsia and hypertension and diabetic pregnancies as well. There's actually a Cochrane review that I'm happy to send the link to, which shows that that diabetic pregnancies stand to gain similar benefit from properly used antenatal steroids. And I assume, Mike, that in a 28-weeker, if the mom is pre-diabetic, you use steroids, just like you would in anyone.
100%. Yeah, I think no matter the maternal medical condition, if a preterm delivery under 34 weeks is anticipated, yes, a course of antenatal steroids is beneficial. As your colleague, Dr. Giamfi, would say, for the Alps study, that late preterm 34 to 36 and 6, that time is where we excluded those diabetic patients. So we should withhold the steroid exposure. And if they've received a prior course, we should not do that in that late preterm setting.
Right. And let me say one more thing about diabetes, that neonatal literature shows, or at least physiologic studies in laboratory setting have shown that in diabetic pregnancies, hyperglycemia leads to increase in insulin, which then in the fetus leads to suppression of surfactant production. And so there is an indirect effect on reducing lung maturity in the fetus and neonate, even when fetal lung maturity testing shows the surfactant is mature.
Okay. We have time for one more question, and then we'll have to wrap it up. But this is about twins, and I know that was, I think, part of your summary, but if you could maybe go over that again, is what is your recommendation for twins? What if only one dose of steroids is used, accelerated dosing? Can you talk a little bit about that? Yeah.
So, Mike, I would, again, love to get your thoughts about this. One thing I didn't mention is that there are studies that are currently still trying to answer these questions. There's one large study that just got started where they're trying to see if a single dose of steroids, of betamethasone, or a different combination of steroids might be as effective and less toxic. From work that we did in my laboratory, our feeling is that one dose of betamethasone is actually all you need. Or if you're going to use 2 doses, then a smaller dose would actually be quite effective. But that's all laboratory based. It still needs to be tested. And until that, we continue to use what has been practiced over the last 30, 40, 50 years. And that's the right thing to do. But please be aware that hopefully in our lifetime, we'll have studies to clarify these simple questions. Why is 12 milligram, a dose that Dr. Liggins used 50 years ago, still the right dose? And then the other thing I wanted to mention, which I listed in one of my slides, Mike, is that as I was reviewing literature for this talk, I came across this consortium for the study of pregnancy treatments. It's called COOPT. It's an international birth cohort to study the effects of antenatal steroids, the study that I saw. They are tracking outcomes in 2.8 million pregnancies and births. And I think that that is the type of information that'll become much more relevant than long-term follow-up in a few hundred babies. We tried to do that in Georgia. What we did is convince the Department of Education and Department of Health to allow us to deterministically link maternal, neonatal, and school education records. And then we stripped all the identifiers. And so what immediately that did for us is gave us the ability to say, okay, Lucky Jain had a grandchild, and 6 years later, how is that cohort of grandchildren born in 2019 doing? How are they doing? And so you could actually compare their gestational age, their gender, their complications, not just through reports that are in the medical record, but also through CRCT testing, which is now mandatory in all schools. So you know whether or not the child is passing first grade or in special education or has good executive learning skills or not. So there's a lot more that is likely to happen in this space, not necessarily through NIH-funded studies, but through very, very good, well-controlled epidemiologic data that will be generated. So I know, Susan, it's way past our time. I know that for a topic like this, we could continue forever, and I would have loved to have some of your audience members to unmute and tell us about their experience and practices, but maybe we'll save that to another occasion. But I wanted to thank you, Susan and Mike, for this opportunity to speak with obstetricians, because I rarely get that opportunity these days.
Excellent. Well, thank you so much, Dr. Jain, and thank you, Dr. Ruma, for joining us. And for everybody who's on the webinar, you will receive a follow-up email from Hologic with more information about today's webinar. With that, we wish everybody a great rest of their afternoon. Thank you.
Thank you all. Thank you again, Dr. Jain.
Thank you.